Oh, yum. Okay, good. Okay, well, we're going to talk about labs. I hope nobody ate anything super greasy and your triglycerides are real high. But our speaker came back yesterday. She must have liked us. Yay. Give a hand for Miss Larson. She's back. She's my friend. She doesn't know it, but we are soul sisters. We're both nephrology nurse practitioners. She is employed by United Healthcare. She makes house calls, another one of my big things. I love that. So today she's going to talk to us about the interpretation and documentation of common labs. And you guys met her yesterday. You heard her bio, so I won't repeat that. But she didn't give a fun fact. And she has two really, really cool fun facts. I had to ask her some questions too. So she is a master canner, C-A-N-N-E-R, which means that she puts food in a jar and then preserves it and does all that stuff, which is old time. My mom does it too. But she takes it to another level and made 100 different recipes of canning stuff and took it to the Utah State Fair and has won not once, not twice, not 3 times, not 4 times, 5 times like Michael Phelps.
Yes.
Yes. So I think that's pretty cool. I asked her what her favorite recipe was, and I'm going to let her tell you.
It's puttanesca sauce.
And then you asked for the interpretation.
Puttanesca means spicy whore in Italian.
Love it. It's got to be great. It's got to taste great.
It's beyond delicious. It's had capers, black olives, or red peppers in it, dehydrated Roma tomatoes. It is quote unquote restaurant quality. So when I'm done doing all the things I do in my life, I'm going to put it in a jar and sell it.
Yes. And be sure you remember us because we want the recipe too.
Thank you.
Okay. And then her other really super duper cool fun fact is she is a stamp collector. Her dad started this stamp collection in 1949, and she has over 30,000 stamps from all over the world, which makes her a geography nerd.
True.
Okay.
Very true.
All right.
Thank you.
You're
Sean,
welcome.
I appreciate it. I like to think I'm a big time nerd that's under medicated. So I always have a little bit of underlying anxiety, which I think propels me to overachieve and to put my hand up for topics that I really don't know anything about, such as common labs and interpretation. So I actually learned a lot when I put this together, and you will see that parts of that are rather robust in information and other parts are a little bit void. And so this is the worst time slot to speak. It is after lunch on the last day and everybody's ready to go home. So please don't text under the table. I know you do it. So I will call out people to help me answer some questions. Oh, holy moly, is this not going to work now? Let me just hit the button. Let's do this. Okay, with disclosures, all of this always needs to be said. Yes, I'm an employee of United Healthcare, and you heard me say that if you have to interface with my employer, I apologize. Imagine what it's like if you work for them. That's all I'll say about them. I am a promotional speaker for AstraZeneca. We will not be talking about any of their medications. I have my own small business, which is the banner that I'm speaking under today. And finally, I am the incoming National Secretary to the Board of Directors of the American Nephrology Nurses Association, which is truly the capstone of my career, and I'm overwhelmed and excited. We have 3 objectives. Actually, originally there were only 2. The first one is to discuss the clinical significance of the information obtained from common lab tests, including CBC, complete metabolic panel, lipid panel, liver panel, and thyroid. We're going to describe a consistent, efficient, and clinically useful method to document. And fourth, we're going to talk amongst us. That was my 3rd objective. Let's have a discussion, because such things as how you document really are dependent upon your EMR and where you work. So let's first start with, okay, I always start when I do a lit review as you Google the topic. Common labs. So boom, this pops up in one of my nurse practitioner feeds, and the article is called Reference Ranges Lab Values for Normal Adults. I thought, oh, perfect. My talk is already made here. So it's an online article, and it had a quick normal reference range. And Kristin Larson, being the gerontological nurse practitioner, as well as a nephrology nurse practitioner, looked at that and thought, I can argue with every single one of these labs because I don't think they're normal. Not for my population, especially hemoglobin, potassium, calcium, creatinine, and ugh, I hate the term normal labs. They are normal for your patient. Creatinine of 1.2 in an 80-year-old versus a 20-year-old is not the same. Please tell me you all know that. Yes, but your lab sheet doesn't. So until the creatinine shows 1.3, it doesn't flag as being high. Who is your population? As I said, please know who you're caring for. I tend to care for a Medicare population. Everybody I care for is over 65, up until my oldest person is, I think I've seen a couple 100-year-olds this year. So actually you've got the young old and the old there. The reference range for your laboratory values is really just a set of a 95% predictive value. It's the mean, median, and mode. It's statistics all over again. So it's just 2 standard deviations from the middle. And I am Kristin Larson. I am way outside those 2 standard deviations in more than one way. That's how normal was defined. Let's get a group of 100 people or 1,000 people together. And what's the normal range for that mineral or that lab test? I loved reading the comments from the article, and I always read comments after professional articles are published, especially the online ones, because you can respond. And I said, each lab has its own methodology and thus its own value range. Anyway, who in the world would memorize these values? That's me. I am really good at kidney labs. I am really bad at everything else because I don't have to remember that. I have a specific population that I care for. We rely on the lab's own ranges, and different labs use different analyzers and different reagents. Then many of the values within the reference range, which I now call herd normal, are not normal for me as the individual. Use clinical intuition, suspicion, and differential diagnosis. I really think sometimes that has gone out the window. I actually see a nurse practitioner for my estrogen therapy that I receive right now. Only she does when she does my multi-million-dollar lab panel once a year is go down the H's and down the L's. And I'll say, well, where was it last year? Oh, I don't have that information. No, you need to look at trends. Normal labs do not mean that you're not sick, and bad labs don't necessarily mean that you are sick. So know what the history is too of your persons that you're seeing. I think that's your biggest take-home message from me today is what's the history of the lab value that's concerning you. And I like your lab results are normal. There's nothing wrong with you. I've heard that before until my patient has a GFR less than 60 and I'm coming into their home and they're saying, now they tell me I've got kidney disease, and we start looking at their past GFRs, and there's been a slow decline in kidney function over multiple years. Why was that trend not caught? So think about this. What is your process for assessing a lab data sheet? Does anybody want to tell me when you get a lab data sheet, is there a process for how you look at it? What's your process, JD? Top to bottom. Okay.
Because I work in the government.
Top to bottom, and because you work in the government.
Top to bottom, and because I work in the government, I can then quickly scroll back through their last labs for the last few years and look at the trends.
Love it, love it. I actually do a quick panning. I go through the whole list and I look for H's and L's. Okay, then I go back to the top and I think, what are my disease processes and what am I specifically looking at? And I relook at that. And then yes, I look at my trends. Let me see if I can get this back on. Is it there? I think so. So next slide here. And this is not working. Kidney function, we would be remiss if I did not talk about this because it's my practice focus. Creatinine is often listed as normal. There again, we've talked about that. I actually calculate GFR on all my people. And my favorite app is from the NKF. I'm not promoting anyone in particular. I just really like that one because you can actually plot it into more than one equation for GFR. And there's about 3 of them out there that are readily used. Urine albumin creatinine ratio. Once again, I talked about that last 2 days ago. I so passionately believe in this because as you can see up here with our heat map up here, if you've got albumin to creatinine less than 30 to 300, which is quite a wide range, or greater than 300, which is not proteinuria, nephrotic at that point, those are all indications of all-cause mortality and cardiovascular mortality. There's even data that says that albumin to creatinine ratio that's 30 should actually be going down to 20 or 25. So please do those. They basically give you an idea of the risk for a progression of kidney disease as well as cardiovascular disease. Personal opinion, as well as opinions from NKF, National Kidney Foundation, diabetes associations, they should really be done on all persons that are diabetic. And what I would like to expand that to all hypertensives. And I just think maybe just because you just do it on everybody at least once in their life. It's not an expensive test. All they're doing is giving a urine sample. I am often the first person to tell somebody they have kidney disease because no one's ever told them that. So go ahead and make sure that you, calculate that. This is just a good example there. I see it wants to jump ahead there. I do want to ask, clearly we want to be on this slide. We're just going to go to that. Okay, you've got a kidney focus. You can tell I'm clearly kidney biased. Do your urine albumin creatinine ratios and do your trends with your GFRs. That's the take home message there. CBC normal levels. Okay, this is one of these where I don't have to know the norms. What I will tell you is that norms for people change. I lived in South Carolina, Charleston, South Carolina for 14 years. I was 8 feet above sea level. You know what my hemoglobin was? About 10.8. So I was not considered normal, but I was normal for the geographic region. I then moved to Salt Lake City, a hemoglobin of 10.8, just like here in Albuquerque. You're going to be short of breath big time. I'm now around 14.5 is my hemoglobin. So yes, erythropoietin does work. Anyway, take a picture of this or it's on your updated slide decks. I decided for this talk that instead of just reading articles, I would query people in the field. And this comes from one of my colleagues in Grand Forks, North Dakota. Yes, people really live there. It's cold and it's raining and it's snowing. Anyway, her pearls from hematology, and she does hemonc, is that know the trend of the CBC. It's like a set of Polaroids in an album, just like I talked about in GFR. Know what that is. What are the other cell lines doing? Are they different from past values? Are there any new medications? Are there any new supplements? I give a talk on supplements. It's called Dining on the Periodic Table. My neighbor said I needed these. And if you actually look at what your patients are taking as supplements, it will just overwhelm you. I would want to know what funky potions they are receiving and taking because they're good for you and they help them. What are the new disease diagnoses? She said the most common reasons that she is consulted from primary care nurse practitioners are an elevated or decreased white blood cell count and an elevated and decreased platelet counts. Steroids, as she said, remind your audience that can cause a mild leukocytosis. She said, before you send them to me, please redraw the value. You want to confirm what you have is really abnormal. Okay, if it's really abnormal, then you order a peripheral smear. She said, please don't send anybody to hemonc for evaluation of anemia or any type of other cell dyscrasia without doing a peripheral smear. Physically have the medical technologist do a count on this. And then she said, and there again, there's the Polaroids. It's a picture. I thought that would be really cool too. If you have the opportunity and you have an in-house lab, go to the lab and find out how some of these tests are done. Otherwise, everything's just put in a tube in a Coulter counter and spun around and then it spits out. This is an actual manual test. Okay. As she said again, what's the hemoglobin trend? Then she said iron deficiency anemia in a man or a non-menstruating female requires upper and lower GI for evaluation of bleeding. Would you agree with that? She actually called it a lawsuit waiting to happen if you don't examine those. She said that's standard of care. Before you send to hematology for evaluation, make sure they have had these recently done. She also said, look at those iron stores, ferritin stores. Ferritin is stored in the liver, as well as transferrin saturation. That's the amount of iron that's readily available to go into red blood cells. What do the red cells look like? And she also talked about macrocytic and microcytic anemia, which is beyond the scope of this talk. I have to take out a cheat sheet and figure out what everything says and map it out, almost like a if that this, then that, when I'm looking at that. Things she did want to say is B12 levels are drawn, especially if people are on metformin, because that can cause a decrease in vitamin B12. Copper deficiency leads to microcytic anemia. The reason I bring this up is that elevated zinc levels in intake can lead to a decreased absorption of copper in the GI tract. This is part of my dining on the periodic table. What is everybody eating tons of lately? Zinc. Why? It's going to save you from COVID. And if one tab is good, then two must be better. I'm wondering if we have people anemic out there because they're, excuse me, overdosed on zinc, which is blocking the copper absorption. Most persons need about 11, I think it's 11 milligrams a day. It's either milligrams or micrograms. Most zinc supplementation is the 50 milligram tablet. So 5 times the amount that's needed. Thyroid studies. I'm going to move on to these. These I am not skilled in, and this one requires a chart for me because there's too much T3, T4 antibodies, various other parts that go along with this. TSH is the most sensitive test to detect thyroid dysfunction. A low TSH is most oftenly diagnostic of spontaneous hyperparathyroidism. Your differential diagnosis for low TSH is right there. Various goiters, adenomas, exogenous sources of thyroid hormone ingestion. Aha, your supplementation. Did you know that there's the supplement, Healthy Thyroid? It's got iodine in it. I have no idea what else it has in it. I would look at that. Recovery phase from treatment for hyperparathyroidism. Hyperparathyroidism is very common in renal disease, and especially when we as nephrologists or nephrology clinicians take out their parathyroid glands, those sit on top of the thyroid, you're actually manipulating the thyroid gland when you excise those, and it can show then a change in your TSH. I would wait and watch on that before you decide to supplement or have intervention with your thyroid labs. And maybe you just had a bad lab, redraw it. When the TSH is abnormal, the next step in the evaluation, the thyroid dysfunction, is to measure your T3, free T4 or T3. All of these various tests are all part of this diagram, which you can download from any thyroid organization or endocrine website. Thyroid antibodies may or may not be part of the evaluation, although not particularly sensitive or specific. And up to 20% of the general euthyroid population may have positive thyroid antibodies. So just because you have antibodies doesn't necessarily mean your TSH is off. Medication use. Certain drugs can result in altered thyroid hormone metabolism and require higher doses of replacement thyroxine, levothyroxine, to achieve a normal TSH. And then various agents there that can either decrease or increase. The person that I see for my thyroid, she really likes a TSH of 0 to 1. I think that's too low. Would anybody agree? Yes. I said my normal TSH is 4.5, and it has been 4.5 my whole entire life. So to zap me down to 0.75, I don't know that you're doing favors for me. And why are you taking it so low? My next question is, do I really need it? I see patients all the time who have been on thyroid supplementation for 20, 30 years. And I say, why do you take it? I don't know. I was told I needed it. Do you still need it now? I really don't know what the long-term implications, if there are any, of being on thyroid supplementation. If you basically have a normal or a higher normal thyroid function study, but I would agree that the medication is given quite often. Your medications, your anti-epileptics can interfere with your thyroid studies, as well as certain cancer medications, glucocorticoids. Final one down here, biotin. This one I learned too. How many of you take hair, skin, and nail vitamins? It's loaded with biotin. If you get your TSH done at the same time, it'll alter your TSH, of which I wish my doctor had told me that, because then he said, well, you know what, you can come back in here and have it drawn. I said, are you going to charge me? Yeah, and then I'm not coming in. Do the math, figure out where I was before. And I would have liked to have known that before. So anything that has biotin in it, and you actually need to be off your biotin for about 7 days. Pediatric functions, thyroid functions. Anybody in here take care of kids? I don't have them. I don't know anything about them. So kudos to you. For children, subclinically elevated TSH can result in a referral to pediatric endocrinology. And oftentimes the author of this study from 2019 says the referral is basically not necessary. There was limited data that was available to assist primary care practitioners to distinguish abnormal labs that reflect actual thyroid disease, requiring treatments from subclinical hypothyroidism requiring only observation. The author of this paper was very into just wait and watch. They're kids, they're growing, they changed. Nevertheless, levothyroxine prescriptions can continue to rise over the time being, over the years, which can lead your child to diarrhea, sleep issues, and anxiety, for which she said, then the kid gets treated for these. That really about 20% of adults, she said, are overtreated, and she really believed that for about children too. So does anybody in here order levothyroxine for children? Do you let pediatric endocrinology do that? It would be whatever you're comfortable with. Oh, you really? Okay. Okay. Well, this gal was getting quite a ton of referrals, which is why she wrote this article. And she wrote that really the author's advice, if concern exists regarding the presence of hypothyroidism and the initial thyroid function tests have revealed a normal free T3 and a TSH above the reference range, just repeat these and carefully examine the thyroid. She said, i.e. actually lay hands on the gland, feel their neck, do an assessment and measure their anti-thyroid antibodies. If you have questions, send to pediatric endocrinology. But her feeling basically overall, and what I took home from this article was that little kids are over medicated with this, and that the sleep issues, diarrhea, and anxiety may be more harmful than the actual mildly elevated TSH. Next slide here. Making sense of common liver tests. Okay, also part of your metabolic panel. This is another one where I just take a picture of because there's really only two in here that I really care about as a renal nurse. That's my my ALT and my albumin. But let's break through what this all means. Making sense. Liver function tests may show abnormalities in even asymptomatic individuals. Liver disease, much like kidney disease, can be silent and can be silent for a time. And more information on liver function tests, go to the American College of Gastroenterology. They have a guideline for every group of people. Let's start with your aminotransferases, your AST and your ALT. They are enzymes found in the liver, convert proteins into energy via transfer of aspartate and alanine, respectively, to ketoglutaric acid. I think that's a good tongue twister, and I did well. Elevations can signal liver injury, not liver function. ALT is primarily found in the liver and more specific marker of hepatocellular injury. AST is also abundantly present in other organs, including your skeletal muscle, cardiac, kidneys, and brain. And if AST is observed without concomitant elevation of ALT, it is suggestive of a non-liver disease such as cardiac or muscular. Also to remember that during short-term illness or infection, such as COVID, your AST and your ALT levels may be elevated. However, if persistent elevations occur, you may want to refer. I was always taught in nurse practitioner school that AST was short-term damage, ALT was long-term damage. Did any of you ever learn that? Maybe that was a South Carolina thing. But if your AST was elevated, my preceptor said, oh, that meant short-term damage. If it was ALT, it meant that they had long-term liver damage. Not necessarily when I really read this article. ALP represents a group of isoenzymes found in the outer layer of the cell membrane that catalyze the hydrolysis of organic phosphate esters present in the extracellular space to an alanine or alkaline pH, abundantly present in the bone, elevated in CKD, and can be seen in renal bone disease. If you are sending to nephrology along with your renal palinol, your urine, albumin, creatinine, if you have an ALP, send it to. This is suggestive of high turnover bone disease in the renal population. Renal population gets a different type of osteodystrophy, osteoporosis, than the normal population. If this is high in that population, it means they're rapidly turning over bone disease. And we really want to last through those people. We do not give them alendronate or the other medications that are out there. Levels are high during childhood and pregnancy. Vitamin D deficiency may be another cause of ALP, elevated ALP, especially in asymptomatic patients. I am crazy about vitamin D. It is really the only supplement I go nuts over. Do you check vitamin D levels? Great. Where do you like your level to be? Okay. 40? Okay, do I hear 50? Okay, I like my levels. This is Kristin Larson's opinion, between 40 and 60. I want them on the higher end. And I want your level to be 40 at Easter and 60 at Labor Day. Because when you go into the Utah very dark winter, you're not making any vitamin D from the sun simply because of the angle. So I want that liver well supplied with its vitamin D to get you through the winter, and I want you at the lower end of 40. That's my opinion. Yes, ma'am. Do I treat it? No, but I call their, because I oversee, I don't treat, I will call their provider or write them on a note so that they hand it and then my referring letter shows it. Next question, can you overdose on vitamin D? Vitamin D3? Absolutely, thank you. I had a patient who, when we added up all the supplements within a supplement, was taking 33,000 units of vitamin D3 a day. I just laid my hand over my heart and said, I'm having chest pain. Because as you're making limestone in your blood vessels, and you're going to start, peeing out rocks, you're going to have kidney stones galore. I called her primary care provider, and the commentary was, Kristin, as you know, you can't overdose this. And I thought, I did not have time to have an argument. And I just said, I respectfully disagree with you. Please read my report when I send it to you. So even though they're only taking their 5,000 unit tablet, take a look at that supplement within a supplement. Elevated ALP in conjunction with a parallel elevation of GGT is suggestive of an underlying cholestatic liver disease. That would mean a bile type disease. GGT is an enzyme found throughout the body, including the kidneys, intestine, prostate, pancreas, and liver. GGT is not found in the bone. Okay, so if they have an elevated one, a GGT, then I know that they're not having rapid bone turnover. Considered a marker of excess alcohol intake. Any condition that damages the liver or the bile causes this. The author did say that alcohol tends to be the most predominant, but nevertheless, you've got to ask. In the great state of Utah, alcohol is not very predominant, neither is coffee. Two liquids that are not used very often there. Anyway, so when I ask my patients, do you have any beer, wine, or cocktails? They're often reluctant to tell me. Because anyway, and then I usually say, in order to get the conversation going, I say, I enjoy a lovely glass of Prosecco in a Waterford stem every Saturday night, or after a bad day of work, whichever comes first. And then they laugh. And then they tell me, well, you know what? I really do have 2 or 3 beers a day. Okay, now let's start adding it up. So what was hesitancy of not really telling me an alcohol consumption? Find out what it is. And you can base your clinical judgments from there on any coaching or any lifestyle changes that need to be done. I don't double. I don't really double. I'm just happy that they actually tell me a number. And then if I get to go back and see them the next year, I will usually say, oh, I see that, you have a beer, wine, or cocktail about every other day or so. Is that still true? And then I'll remind them that I still like my Prosecco. And sometimes the number will go up. Sometimes the number goes drastically up. I'm like, holy moly. Last year it was 12. Now it's 34. What's happened in the last year? So I'll dig deeper in that. Bilirubin serves as a marker of both liver injury and hepatocellular function. It's the breakdown of red blood cells. Most laboratories assess bilirubin levels, which comprise both conjugated and unconjugated. You would have to ask for that if you want that fractionated. And basically, in the setting of an elevated bilirubin level, fractionation may be helpful to elevate or to evaluate what's basically the liver process that's going on. And then it talked about it could be suggestive of hemolysis or something called Gilbert syndrome, which is the inability of the liver to process bilirubin. If you had a bunch of abnormal LFTs, would you just refer them in your practice? I would, because this is not my forte. And finally, albumin. Okay, this is another one that renal medicine gets excited over. Albumin obviously is a protein exclusive of the liver that serves a variety of functions. Obviously, many of your medications bind to albumin, serves as oncotic pressure, which competes with hydrostatic pressure, especially going through the glomerulus. It's the most abundant circulating protein, and the liver there again is the only organ that produces this. Serum albumin may be suggestive of impaired liver function. I also want to say it's part of kidney function. As kidney function declines, so does appetite and intake of nitrogenous products, i.e. protein. If you are not taking in any protein, it's not uncommon for a person with advanced or severe kidney disease to also have a low albumin. So that would be a good lab test if you wanted to include that with a referral. Next one. Lipid levels. It's all about risk factors. Here again, reading the various articles that were out there, it was all what is the comorbidity of the person that you're looking at? What is the age that you're looking at? You obviously have your total cholesterol, which is composed of both low density protein and high density lipoproteins. LDL, obviously listed as the bad cholesterol, or as I like to remember, you want your lows low. Your HDL or your good, you want your highs high. Your non-HDL is your total cholesterol minus your HDL. And then your triglycerides, which are another form of fat and can raise your risk for heart disease. It said more so in women than men. A normal triglyceride somewhere around 150 or so. Have you all seen triglycerides in the thousands? Yes, refer, yes. I used to have a cholesterol level of 240 and my HDLs were 100. But my primary care doc didn't like the fact that my total cholesterol was too high. So now my HDLs aren't 100 anymore, but at least they're greater than 50. Here again, a nice chart that just shows if you're younger than 19, where you should be. This comes from the National Institute of Health. If you're a man over 20 or a woman over 20, this is basically what they state you want to be. Thanks with atorvastatin, I am now in all these healthy ranges where I should be. Here are some guidelines, and I found these interesting too that come from NIH. The first test for cholesterol, triglycerides, should be between age 9 and 11. Is pediatric NPs, do you do that? Do you check cholesterol in little kids? You do. Are you finding that they're elevated? You are. Do you put little kids on statins? No. Do you do diet changes? Okay, yes. And that a child should have this every 5 years. It went on to state that if some children may have this test at age 2. Have you ever done a cholesterol on somebody age 2? No. And they recommended that if there is a strong family history of high blood pressure, high cholesterol, stroke, heart attack, any of those cardiovascular events, go ahead. After age 20, you should have it done every 5 years. And if you're a man between 45 and 65 and women 55 to 65, every 1 to 2 years. In looking at where your cholesterol levels should be and when initiation of medication should start, American Heart, American College of Cardiology, National Kidney Foundation, and US Preventative Task Service all have specific guideline and decision trees, which are just went on and on and on. Pearls from a new NP. Do we have anybody in here who's new? Like less than 1 year of practice? Yay, welcome to the profession. I mentored a lovely young nurse practitioner that just got out of Vanderbilt University, and now she's practicing in Billings, Montana, pulling her hair out as one does with their first NP job. And I said, tell me the things you wish you had been told or you wish your preceptor had told you. And she said, the first one is to just reinforce that, make sure the lab value is connected with the differential, and will this lab value really change your plan of care? I think that's basic nurse practitioner school. We don't do it unless it's going to change your plan. She said, pick 1 or 2 resources, texts, or apps to be your go-to source. This was her favorite book. She actually took a picture of it and sent it to me. And she said, the handy fact sheets, wherever are your charting stations, have the list of the norms for your institution, your lab values. And just handy references for anemia and CKD, basically wherever you sit in chart. She also said it would be really helpful if I could just go to the lab, and I talked to her about the peripheral smear for anemia, and she said that would be so cool. So if you have the opportunity to ever go down there, or if nothing else, just meet someone down there, shake some hands. So if you ever really needed, you know, some advice or some help or advocating, yeah, make friends with people. Bring cups of coffee. It does a wonder. And then finally, advice from the field. This I interviewed a nurse from Cedar Rapids, Iowa, as well as Jackie from Grand Forks, North Dakota. And that's basically said, what would be your advice for charting of labs and the process? Actually, all abnormal labs are flagged in the EMR. Is that a true statement? Yes? No? Yeah. Okay. What is your office policy and procedure? Do you actually have a written policy for what to do with abnormal labs? JD, you're shaking your head. I do medical malpractice and I defend nurse practitioners. I don't do defense only. I mean, don't do prosecution, only defense. Oh my gosh, you've got to follow what you've got written, because that is the primary document that's going to protect you in a court of law. When you learn how to do all of your lab charting, is it on the job, or do you actually have an orientation? That's something else to think about. What is your process for addressing and acting on these labs? And labs are requiring actions are trackable and traceable. Everybody has an electronic signature on this. Finally, do most of you have a nurse or medical assistant who you delegate tasks to? So you're actually calling the patient to tell them what their labs are? Okay, you are. Some of them don't, they delegate it. If you are delegating this to, I like to think, a third party, can you trust that third party? Or does it sit in their inbox till a Monday morning when they received it on a Friday? Know who it's going to. Network with your peers in various specialties. Use them as a springboard for further investigation of unknown labs. Okay, I have my HEMONC contact. I obviously have CKD contacts. I'm going to be your contact for renal if you want me to be your contact, but make friends with other people. You simply cannot remember everything, but you can know somebody who does, and who could at least do a curbside consult. Hey, I've got this person, these are their labs. Do you think that I should further refer, or what else would you like me to do before I send them to you? It's not a bad idea. And finally, attend an educational session or join an organization outside your field of practice. I belong to wound continence and ostomy nurses. I never knew that wounds could take 2 to 3 years to heal. They really do. That just blows me away. And with that, I think I actually have a few minutes. Here's my references. There's my picture. And what time are we at? Seriously? Wow, I talked faster than I needed to. I thought I only had 45 minutes. Yeah, I have 7 minutes. Whereas I went over on my last talk, I'm under on this one. Okay, any questions? Okay, good, we've got questions.
Hi, so with chronic kidney disease, are you a fan of Farxiga? And then there was a new medication that I heard about at this conference that is supposed to help with chronic kidney disease.
I don't know if I can politically answer that question or not. I can answer that in public, I mean in private. I'll come and talk to you.
Okay.
Okay. And that's because of my relationship with AstraZeneca. I can't do that. Oh, the question is, can I endorse Farxiga? And I said, because of my relationship with AstraZeneca, I don't want to publicly say anything, but I will privately talk to you.
So one comment and one question. In New Mexico, probably most people know this, but you can call UNM. It's 1-888-UNM-PALS and automatically reach a specialist in any field.
Oh, wow.
So it's a really nice resource we have. And I think most people probably know this, but if anybody new does not know. So as far as calling a colleague, that is one of my favorites for places where I don't necessarily know a neurosurgeon personally. So 1-888-UNM-PALS.
You are the first institution I have ever heard that.
Oh, they've had it for 20 years. They're amazing.
So you really can just say, hi, I'm so-and-so, I've got a question about these kidney functions, and someone will, they'll call you back.
They'll call.
Great.
Sometimes they'll even get on the line right away. So
Yeah, now with Vocera, they get notified immediately. It's not like a pager
Yeah.
and then they answer when they can or whatever.
So is the person answering these questions then obviously a clinician? Good.
They're a
okay,
clinician in the specialty you need, so,
Good. Oh, I love it.
yeah. And then I was wondering if you could comment on the current trend away from having different GFRs for the same creatinine and other numbers for African Americans.
That has been abandoned. That has been taken away to the
They're
best of
still
my
doing it in
knowledge.
some of our labs.
Yeah,
but,
by the National Kidney Foundation. Yeah, and it's the right thing. It needed to happen. Yeah, so that distinguishing factor of African American or not is gone in the equation. Any other questions? Someone has to have another kidney question. Seriously, it's the sexiest organ ever. Who said that? I like to think of the talking heart talks to the failing kidney, and they both secrete chemicals to try to help each other, and they only make it worse. So takeaway points, you're looking at trends when you look at lab values. It's not a Polaroid, it's a trend. Refer to nephrology. If questions, call this wonderful number. Oh my gosh, you should have nobody with CKD falling through the system, although people will, but at least you have a stopgap in place. Anybody in here who takes care of children, who has commentary on child labs? You want to?
Child labs are wacky.
Thank you.
Yeah. I mean, it's like sometimes you look at stuff and you're like, oh, well, that looks really off. Then you're like, well, that kid's only like 36 hours old. So yeah, a hematocrit of 60 is fine.
Okay.
Right?
Okay.
And then you like wait for the Billy to pop up the next day.
Okay.
But yeah, you get a lot of that stuff or they're so water filled.
Okay.
Right? And they're so sensitive to that. And if they're coming dehydrated, you have no idea what the labs really are. And so sometimes we'll like do their labs. We know they're dehydrated, rehydrate them, and then like double check just to be sure what we're looking at is real.
Good.
Yeah.
Very good. And so as a pediatric nurse, do you, in your memory bank, have a set of labs that you know are norms?
Well, yeah, we use Epic.
Okay.
So it pulls up the norms, kind of flag the highs and lows, but
Okay.
you really have to use a lot of clinical judgment
Good.
as far as that goes to before you like you might have some labs that don't show that they're dehydrated, but then you look at the kid and their lips are all cracked and all that other stuff. And you're like, they are dehydrated. I don't care what you say, labs.
Great.
So-
So it falls into the statements from my first slide that, yes, your clinical decision-making will basically, it's your beacon. It's what's going to guide you in how you do, not just what a piece of paper says. Oh, another minute and a half, this lady.
I think I asked this question yesterday and I didn't really feel like I got a great answer.
Okay.
So uric acid in kidneys. What do you think about that? I mean, do you see people's kidneys when they have very uncontrolled uric acid, gout, like affecting their joints? Do you see that as a cause of kidney failure sometimes?
Yes, it can be a cause of kidney. And Shauna also here's a nephrology nurse practitioner. Yes,
Okay.
I see it as a cause of kidney failure, but more so I see the chronic stable end. And are you taking your agents every day versus taking it only when I feel bad? That I think is more harmful to the body when people PRN their gout medications. Gout as a cause of end-stage renal disease or kidney impairment is very, very rare. It's we're seeing diabetes and hypertension. So when I see someone whose gout level was out of control and now this is why they've got CKD, to me, that is someone who missed access to care and intervention early. But for the most part, that's a zebra and not a horse. I would go to rheumatology so fast to make your head spin. Yeah. Is that a better answer? Yes. Okay, very good. It's like I said, it's a real, and I've never seen anybody with the humongo limbs. I've seen, tophi that are impressive, but not any that are just out of this world. Okay, so is he seeing rheumatology?
He's at this point end stage renal disease. He
Okay.
does not want any treatment. He
Okay.
is at that place where it's over. But when I look at his ankles and I see what's happening with the gout, and I had another patient who went to nephrology because his kidneys started to just really decrease, and he had a gouty elbow. And she said that was what she thought caused his kidney disease. He didn't have high blood pressure.
Okay.
He didn't have diabetes. And that was really a big lesson for me. I had that never crossed my mind.
So because of that, are you good at looking at uric acid levels?
Oh, yeah, I look at for uric acid
Thank
all the
you.
time now.
Excellent. Time is up. Okay, if you have any questions, come on up here. If you want my card, I'm happy to be your kidney resource. Don't agonize. Just call me. I'm freakishly fast about answering a text. Anyway, and thank you. And I hope to see you next year. Thank you.